Okay, let's dive into this. Um, Picture this. The main blood vessels going down to your legs and pelvis. Imagine they have these little hidden weak spots, kind of like bulges.
Yeah, exactly. Those are iliac artery aneurysms.
And you know what's really surprising is how often they just get found completely by accident.
Right. They're tucked away deep inside, so you might never know it's there. But if one ruptures, well, that can be very serious.
Very serious.
And what's fascinating, especially with these isolated iliac artery aneurysms, that means they happen without a related widening higher up in the aorta, is just how silent they can be.
Hmm.
So today, we're really going deep on these isolated IAAs. We're drawing heavily on Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
A fantastic resource.
Definitely. And our goal isn't just to, list facts, but to really get a feel for what makes these conditions happen and how we manage them.
Exactly. Now, you might be listening and thinking, okay, never heard of this. Why is it relevant to me?
Well, it's about understanding your own body, isn't it? The surprising things that can occur.
And it's also a window into how incredibly far medicine has come in tackling these kinds of, well, hidden dangers.
Right. Consider it a way to get really informed about a vital part of your circulation.
Okay, so the mission for this deep dive.
Basically, to unpack these isolated IAAs. What are they? Why do they form? How do we find them? And crucially, what are the latest ways we approach treatment?
Going from the basics right up to the cutting edge.
Precisely. Foundational knowledge, then the latest techniques.
All right, let's start with the absolute basics then.
Yeah.
What actually defines an iliac artery aneurysm? We're talking about those arteries feeding the pelvis and legs, right?
That's the ones. And whether it's the common iliac artery, the CIA, or the internal iliac, the IAA, or even the external iliac, the EIA, though that's much rarer,
Okay.
we say it's aneurysmal when its diameter gets to be about 1.5 times what we'd expect for a normal, healthy artery of that size.
So is that significant widening?
Hmm.
And location-wise, where do these tend to show up most often?
The common iliac artery, the CIA, is the big one, by far. You see that in, say, 70 to 90% of cases.
Wow, okay.
The internal iliac artery, the IIA, that's involved maybe 10 to 30% of the time.
And the external.
The EIA, very rare for isolated ones, maybe 3 to 4%. And interestingly, in at least half the cases, you actually find aneurysms in both common iliac arteries, bilateral CIAs.
So it could be a double issue. No, they might sit there quietly, but why are we so concerned if they do become a problem? What's the main danger?
The primary worry really is rupture. Because they're so deep in the pelvis, they can grow quite large without anyone knowing.
Right.
And if an IAA ruptures, you're looking at emergency surgery. And sadly, the mortality rates in that situation, they can be incredibly high, anywhere from, well, 0 in some reports, but up to 75%.
It's a huge range, but sobering at the top end.
It is. Now, elective surgery, finding it before it bursts and fixing it, that has a much lower mortality risk. Still significant, maybe 0 to 33%, but much better.
Oh.
Part of the issue with rupture is just the technical difficulty of operating in the area emergently.
Right. Deep location emergency situation.
Yeah.
Makes sense. So hidden, potentially lethal if they rupture. That really hammers home why knowing about this is important.
Yeah.
Okay, so how and why do they actually form? What causes these weak spots?
Well, it's usually multifactorial. There isn't just one single cause. It's a mix of things you might acquire, lifestyle factors, other diseases, and some inherited risks, too.
Okay.
Rutherford's Chapter 71 actually goes into the general causes of arterial aneurysms more broadly, if you want the bigger picture.
Gotta know. But for these specific iliac ones, what are the main culprits, the most common risk factors?
The two that stand out consistently are hypertension, high blood pressure, and cigarette smoking. Those are the most prevalent, definitely.
Okay, the usual suspects in vascular disease. Are there other, maybe less common, triggers?
Yes, several. Things like previous trauma to the area, iatrogenic injury, meaning something caused during a medical procedure, certain types of arteritis, which is inflammation of the arteries, connective tissue disorders that weaken vessel walls, and even infections.
Infections. How does an infection cause an aneurysm?
Yeah, what we call mycotic aneurysms. Historically, things like syphilis and tuberculosis were implicated.
Okay.
Nowadays, the bacteria we see most often are Salmonella and then Staphylococcus. Although, interestingly, a study from China looking at infected aortic and iliac aneurysms found mostly gram-negative bacteria like Salmonella, Klebsiella, E. coli.
That's interesting.
And we've seen rare fungal ones too, like Candida. It's worth remembering, though, that if you look at all mycotic aneurysms in the body, staph is still generally the most common bug overall, so it varies a bit.
fascinating how the infectious causes have shifted. Now, you mentioned earlier they prefer the common and internal iliacs, but usually spare the external. Do we know why? That seems like a really key question.
It is key, and we don't have the full answer yet, but research suggests there might be inherent differences in the artery walls themselves. Studies looking at DNA expression show distinct profiles in different parts of the aorta and iliacs.
So, like, different genetic blueprints for different sections?
Potentially, yes. And one leading theory involves how these arteries develop in the embryo. The smooth muscle cells in the external iliac might come from a different lineage than those in the common and internal iliacs.
Wow.
And those latter two are the ones more prone to aneurysms, right? There's also immunobiological research suggesting differences in characteristics, phenotypes, between the internal and external iliacs, also linked back to their embryonic origins.
So how we developed before birth could literally influence this decades later. Amazing. What else plays a role?
Changes in blood flow patterns are definitely important. Disturbed flow.
How so?
Well, there was a study on WWII vets who'd had above-the-knee amputations. They were much more likely to develop aortic and iliac aneurysms compared to guys with similar risks, but no amputation.
Really?
Yeah, and even the shape of the aneurysm seemed to correlate with which leg was missing. It suggests that asymmetric flow really stresses the system.
That makes sense.
We also see them form sometimes just upstream from arteriovenous fistulae, those abnormal artery vein connections in the pelvis or leg. Again, altered flow dynamics.
Right. And you mentioned different shapes of common iliac aneurysms too.
Yes, researchers have identified three main types based on shape. Complex, involving the bifurcation point. Fusiform, which is that sort of even spindle shape. And kinked, right after a sharp bend.
Okay.
And sophisticated blood flow modeling, computational fluid dynamics, shows these abnormal flow patterns in the CIA can even distort the aorta above it, making it deflect towards the side with the aneurysm.
Whoa.
And they've confirmed this by looking at patient scans, too. It's just how interconnected everything is down there.
Wild. Okay, so they form for various reasons, often stay hidden. What about their natural history? How do they behave over time if left alone? Do we know much about that?
Yeah, that's a tricky area because we don't have huge amounts of prospective data specifically on isolated IAAs. A lot of what we know comes from looking back at case series.
Retrospective studies.
Exactly, but they give us clues about things like how often both sides are affected, maybe up to 65% in some reports, and importantly, how fast they tend to grow.
And what do we know about growth rates? Is it slow and steady or unpredictable?
It seems related to size. Smaller ones, say 3 centimeters or less, they tend to grow pretty slowly. On average, maybe 0.05 to 0.15 centimeters per year.
Okay, quite slow.
But the larger ones, over 3 centimeters, they pick up the pace. Average growth is more like 0.26 to 0.29 centimeters per year.
So double or triple the rate.
Roughly, yeah. And interestingly, whether or not someone also has an abdominal aortic aneurysm doesn't seem to make a big difference to the iliac growth rate.
Good to know. So size matters for growth speed. Now, rupture the big fear. How likely is that?
They do have a significant tendency to rupture because they can be asymptomatic for so long. Sadly, rupture is sometimes the first sign. Early reports suggested maybe up to 42% presented at rupture.
42%, that's high.
It is, and just to remind everyone of those mortality numbers.
Yeah, let's recap that. It's critical.
Emergency repair for rupture, mortality is around 28% on average, but the range is huge, 0 to 60%. Whereas elective repair, planned surgery, the average is around 5%. Again, with a wide range, maybe 0 to 50%, but much lower overall.
Big difference. Does size predict rupture risk strongly? Is there a typical size where they tend to go?
The average size of ruptured IAAs is usually reported somewhere between 6 and 6.8 centimeters.
Okay.
For the rare external iliac ones, rupture seems to happen when they're over 4 centimeters. For internal iliacs, the median rupture size is around 7.7 centimeters, but that varies hugely from 2 centimeters up to 13 centimeters in some cases.
So quite variable for IAAs.
Very. And what's concerning is even with modern imaging being so common, some studies still show almost half of all IAAs presenting as a rupture when first discovered.
It's still incredibly high even now.
It is. Looking specifically at ruptured internal iliac aneurysms, a European study found that almost all of them, 94%, ruptured when they were bigger than 4 centimeters. Very few ruptured below that size.
Okay, so 4 centimeters seems like a key threshold for IAAs.
It seems that way. And generally, the thinking is that uncomplicated IAAs smaller than about 3.5 centimeter rarely rupture,
Right.
which is why the general guideline for elective repair in asymptomatic cases kicks in around that 3 to 3.5 centimeter mark. Though, again, location, growth rate, patient health, it all plays a role.
And symptomatic ones get repaired regardless of size.
Absolutely. If it's causing symptoms, you fix it. Size doesn't matter then.
Okay. So apart from the catastrophic rupture, what kind of symptoms might someone experience before that point, given how hidden they are?
Yeah, that deep pelvic location is the problem. Often, even big ones aren't felt on a physical exam. Symptoms can be really vague, maybe a dull ache in the lower abdomen or pelvis.
Why?
Just pressure, the aneurysm pushing on the bowel, bladder, nerves, veins nearby. But that kind of pain is so nonspecific, right? It could be anything.
Easily mistaken for something else. What about less common, maybe more specific clues?
You might get intermittent claudication, that leg pain with exercise that goes away with rest, or just leg pain from tiny clots breaking off the aneurysm and blocking smaller arteries downstream called emboli.
Okay.
Rarer still, things like leg weakness, nerve pain like sciatica, low back pain, urinary blockage causing kidney issues, that feeling of needing to go to the bathroom constantly, tenesmus, constipation.
Wow, quite a list.
Even very rarely, a DVT, a blood clot in the leg vein because an internal iliac aneurysm is squashing the iliac vein. So yeah, the symptoms can really run the gamut and be quite confusing.
Definitely sounds like it. Now let's talk about rupture again. What are the absolute telltale signs if that happens?
It's usually sudden, severe pain, abdomen, groin, flank. Often comes with signs of shock from blood loss, rapid heart rate, low blood pressure, feeling dizzy.
Okay.
The initial bleeding might be contained for a bit in the space behind the abdomen, the retroperitoneum. But if it's not controlled fast, it leads to irreversible shock.
And delayed diagnosis is a killer there.
Absolutely. Getting the diagnosis quickly is crucial for survival, whether surgery happens or not. Delay is a major factor in those high mortality rates.
Understood. What about those clot-related symptoms, thromboembolism? Can that be the first sign sometimes?
Yes, though it's less common than presenting asymptomatically or with rupture. Sometimes a clot forms inside the aneurysm sac.
Okay.
If it just narrows the artery, it might cause claudication. If a piece breaks off and travels down the leg, embolizes it, can cause acute ischemia, lack of blood flow.
Right.
One study did find patients presenting initially with claudication from thrombus narrowing the artery or leg ischemia from emboli, so it definitely happens, just not as often.
So lots of potential presentations, often subtle.
Yeah.
How do we actually find these things then, if physical exams often miss them?
Yeah.
What's the go-to diagnostic tool?
Yeah, physical exam's unreliable. Ultrasound is really the main initial tool, especially for screening asymptomatic people who might be at risk. But ultrasound has limitations. The quality depends a lot on the technician's skill, the patient's body size, bowel gas obscuring the view,
Right, so it's a good first look, but maybe not the whole picture. What if you need more detail?
Exactly. For a more comprehensive look, especially if things are complex, CT angiography, CTA or MR angiography, MRA, are invaluable. They give you those detailed cross-sectional images.
But they have downsides, too.
Yeah, you have to consider the cost, radiation exposure with CT, contrast dye risks with both. It's always a balance.
Makes sense. Now, let's say an IAA is found and you're planning treatment. What imaging is absolutely essential before heading to the operating room or the endovascular suite?
For planning any kind of repair, open or endovascular, high-resolution CT angiography is pretty much standard practice.
Why CTA specifically?
It gives you that incredibly detailed 3D roadmap. Surgeons need to know the precise location, diameter, length of the aneurysm, but also the length of healthy artery above and below it.
Those are the landing zones, right?
Exactly, crucial for anchoring an endograft. The CTA also shows how twisty the arteries are, any blockages, whether the internal iliacs are open, the state of the deep femoral artery, any other aortic issues. It's a full assessment.
Sounds incredibly detailed. Absolutely vital for planning. Okay, so we found one. We know its characteristics. What actually triggers the decision to repair it?
Generally, two main things. If it's shown to be getting bigger on follow-up scans or if it starts causing symptoms.
Regardless of size for symptoms.
Right. Symptomatic equals repair.
And for the asymptomatic ones found by chance, what's the current thinking on when to intervene?
The consensus, based on clinical experience and expert opinion, generally leans towards elective repair for asymptomatic IAAs once they reach about 3.5 centimeters or more,
Okay.
especially in patients who are otherwise reasonably healthy and can tolerate the procedure well. But again, it's not absolute. Location, complexity, growth rate, patient health all factor in.
We talked about the high mortality of rupture. Has widespread CT scanning in emergency rooms actually helped improve those outcomes?
Yes, definitely. Having CT readily available means we can diagnose ruptured IAAs much faster now than in the past. Less delay in diagnosis has certainly helped reduce the associated morbidity and mortality.
That's good news.
But it's crucial to remember ruptures of previously undiagnosed IAAs still happen, and they're still incredibly challenging emergencies. So it highlights the need for maybe better awareness or screening.
Right. Still a major problem when it occurs. You also mentioned endovascular techniques being used even for ruptured IAAs. That sounds pretty advanced for an emergency.
It is. There have been successful reports. Sometimes they use an aortic occlusion balloon temporarily placed higher up to control the bleeding,
Okay.
often combined with putting coils into the internal iliac artery on that side and then placing a covered stent graft in the common and external iliac to seal the hole.
A complex maneuver in a crisis.
Very. It can be life-saving, especially for unstable patients. More recently, iliac branch devices, we'll talk more about those, have even been used in ruptures trying to preserve pelvic flow. And there are some off-label techniques too, like using an aortic graft component in reverse for ruptured IAAs.
Wow.
But while these endo tricks can be vital acutely, the long-term durability of some emergency fixes is still being studied.
Makes sense. Okay, let's circle back to screening. You said no specific guidelines for isolated IAAs. What are the broader recommendations for screening the aorta and iliacs? Who gets checked?
Correct, no dedicated IAA screening guidelines. But the U.S. Preventive Services Task Force, the USPSTF, has recommendations for abdominal aortic aneurysm screening, which usually includes a look at the iliacs.
And who do they recommend screening?
Since 2005, they've recommended a one-time ultrasound for men aged 65 to 74 who have ever smoked.
Okay, smokers.
They also suggest selective screening for men 65 to 75 who never smoked but might have other risk factors. But importantly, they recommend against routine screening for most women in that age group who never smoked and have no family history.
What about women who have smoked or have a family history?
For them, the USPSTF says the evidence is currently insufficient to make a recommendation either way. But vascular societies, like the SVS, often advocate for broader screening for both men and women to catch more of these before they rupture.
So still some debate there.
Yeah.
What about the small IAAs that get found, maybe incidentally, that are below that 3.5 centimeter repair threshold? How are they managed?
Yeah, those smaller asymptomatic ones, usually under 3 centimeters, are typically managed with surveillance, regular follow-up imaging.
Just wash and wait?
Essentially, yes.
Yeah.
Watchful waiting with imaging to monitor for any growth that might push it towards needing repair.
How often are those scans done? Is there a standard schedule?
It's not perfectly standardized. European guidelines often extrapolate from AAA surveillance data because we lack specific IAA data. U.S. guidelines are a bit less specific on timing, but a UK survey gave some useful insights. They found most labs start watching CIAAs when they hit 2.0 to 2.9 centimeters.
Why?
They saw growth in most over time, averaging about 1.5 millimeters a year. Interestingly, they noted the smaller ones, under 3 centimeters, actually grew slightly faster on average, while the bigger ones, over 3 centimeters, had more unpredictable growth.
Huh, that's counterintuitive. Smaller, growing faster.
A bit, yeah. Based on that, the UK group proposed a surveillance protocol where the scan frequency depends on the size. Very small might be every 2 years, slightly larger might be annually, so smaller ones might need closer watching initially.
Good to know. Now, what about after a successful repair, open, or endo? Is the patient done with monitoring?
Absolutely not. There was a study that followed patients after isolated IAA repair. They found that even with a good repair, the aorta above the treated iliac artery sometimes continued to enlarge over time in some people. Yeah, it really drives home that aneurysm disease is often systemic. It affects the whole system, not just one spot. So long-term surveillance of both the aorta and the iliacs is crucial, even after a successful IAA fix. Gotta watch the whole neighborhood.
Makes perfect sense. Okay, we've covered diagnosis, triggers for treatment. Let's get into the repair options themselves. Starting with traditional open surgery, what are the challenges there?
Open repair, as we mentioned, can be tough. Deep pelvic location, veins stuck to the aneurysm, calcium in the artery walls. It all increases the risk of bleeding during surgery.
Sounds challenging.
It is, but in experienced hands with good exposure using modern retractors, open surgery for isolated IAAs can give really excellent long-term results. It's generally well tolerated by patients who are lower surgical risk overall.
What are the main goals of open surgery, and how do they typically approach it? What incision? What are they trying to achieve?
The main goals are twofold: stop the aneurysm from rupturing and maintain good blood flow to the legs and pelvis. The incision choice depends on the aneurysm, if it's one side or both, and surgeon preference. Could be midline down the abdomen, retroperitoneal from the side, or even a wider transplant-type incision for maximum exposure.
Okay.
Bigger, symptomatic aneurysms usually need enough exposure to safely open the sac, control bleeding, and sew in a graft. If there's a healthy bit of common iliac artery above the aneurysm, you can often just replace that segment with a tube graft.
And if the whole CIA is bad?
Then you might need to go higher, control the aorta itself, and attach the graft directly to the aorta. That usually requires a bigger abdominal or retroperitoneal approach.
And where does the other end of the graft usually connect down towards the leg?
Most often it connects right at the bifurcation, where the common iliac splits into the external and internal iliac arteries. That preserves flow down the leg via the external and into the pelvis via the internal. Less commonly, if the aneurysm involves that split or extends down the IA, the graft might need to connect further down onto healthier segments of the external or internal iliac.
You mentioned preserving pelvic flow. Does open repair have advantages there in terms of collateral supply?
Yes, actually. Direct open repair tends to preserve those smaller collateral vessels like the lumbar arteries or the inferior mesenteric artery, because the aneurysm sac is usually just opened and left in place, not totally removed.
So those side roads stay open.
Exactly. That helps reduce the risk of ischemia, like poor blood supply to the colon or pelvic organs after the surgery. And yeah, for surgeons usually avoid taking the whole sac out unless they have to, because that risks bleeding and injuring nearby veins or the vena cava.
Makes sense.
Putting ureteral stents in beforehand can also be helpful to identify and avoid injuring the ureters, especially with tricky inflammatory aneurysms.
What about that internal iliac artery specifically? How vital is it to keep flow going through that during open repair?
Generally, maintaining flow through at least one IAA is considered really important for the best outcomes, especially in younger patients or if the IAA on the other side is already compromised.
Why is it so important? What happens if flow is lost?
Losing flow to both IAAs can cause problems like buttock claudication pain when walking, erectile dysfunction, and rarely but seriously, things like colon ischemia, buttock tissue necrosis, even spinal cord problems.
Wow, serious consequences.
Yeah. So if both IAAs are diseased, the recommendation is usually to try and bypass at least one of them during the repair. One study even suggested if both IAAs are blocked, you should reimplant the inferior mesenteric artery into the graft to protect the colon's blood supply.
Okay, what if the aneurysm is just on one side? Can you just tie off the IIA on that side?
Sometimes, yes. Unilateral IAA ligation might be tolerated without major issues in many patients if the other side is healthy. But there's a catch.
What's
If the part of the IAA downstream from where you tie it off is also aneurysmal, it could potentially keep enlarging over time due to backflow from other small branches. So it's not without risk. It's a careful balancing act.
Definitely sounds like it. Complex decisions in the OR. What are the typical outcomes for open repair in good centers?
In experienced hands, it's a very durable fix. Elective mortality rates are low, generally 0 to 5%, depending on the patient. Overall complication rates can be up to maybe 22%, including things like leg ischemia, bowel ischemia, graft issues, nerve, or vein injury.
Okay.
But long-term problems specifically with the graft itself are pretty rare. Graft patency keeping it open is excellent, close to 100% at 5 years usually.
That's very reassuring long term. Now, moving on from open surgery, you mentioned endovascular repair is becoming much more common. Why the big shift?
Yeah, just like with aortic aneurysms, there's been a huge trend towards endovascular first for isolated IAAs over the last, say, 20 years. European guidelines now even recommend it as the first-line treatment if it's feasible.
And the reasons?
The advantages are appealing. Shorter hospital stays, less blood loss, less need for ICU monitoring, and generally lower rates of complications right around the time of surgery.
Makes sense for the patient.
And studies show the total number of iliac repairs has gone up since endo became common, while deaths from rupture or repair have actually gone down, so it seems to be having a positive overall impact.
So, clear immediate benefits. But what about the outcomes? How does endo stack up against open long term? Are there downsides?
Well, reports generally show better perioperative morbidity and mortality with endo, less immediate risk.
What?
Some studies suggest a higher need for reinterventions, follow-up procedures down the line compared to open surgery.
Oh.
For
Oh.
example, one study showed high initial technical success with endo, but a fair number needed more work later, and endo leaks, blood leaking back into the sac, were pretty common.
How common?
Rates vary, but definitely higher than ideal sometimes. Another study directly comparing open versus endo found no difference in short-term outcomes or long-term survival. But the risk of needing another procedure later was significantly higher after endovascular repair or after emergency repair for rupture.
Right. What about complications like ischemia?
A big meta-analysis suggested endo might have a higher risk of ischemic issues like buttock claudication, bowel problems, ED, compared to open. But it also showed less need for transfusions and shorter hospital stays with endo. Mortality and wound complications were similar.
So trade-offs.
Exactly. The long-term graft patency and reintervention data in that meta-analysis were a bit murky. However, a series using a totally percutaneous endo approach, just needle sticks, no incisions, showed really good graft patency at 1 and 4 years.
Interesting. So endo offers immediate gains, maybe more follow-up needed. What's the main goal of the endovascular approach? What are they trying to do?
Fundamentally the same goal as open. Exclude the aneurysm sac from blood flow,
Hmm.
stop the pressure, prevent enlargement, prevent rupture, and to help plan these endo repairs, there are classification systems, like the Reber classification, types I to IV, based on anatomy. It helps choose the right technique and device.
Gotcha. So how does a typical endovascular repair for a common iliac aneurysm work? What's the standard technique?
You generally need about 2 centimeters of healthy artery above and below the aneurysm, those landing zones we talked about, to get a good seal with the stent graft.
Okay. What if you don't have that 2 centimeter above?
Then you often have to extend the graft higher up into the aorta itself. Depending on how high it goes, you might use a bifurcated aortic endograft, one body in the aorta, 2 limbs down into the iliacs.
Right, bridging the gap.
Exactly. And if the landing zone right below the kidney arteries is short, there are specialized techniques like the double barrel or double D to land 2 iliac limbs side by side in a short aortic cuff, protecting renal flow.
Clever. What about sealing the lower end? Any specific challenges there, especially if the artery is wide?
Yes, getting a good distal seal can be tricky, particularly in wide iliacs. Historically, for wide distal CAAs, say over 16 millimeter, they used flared or bell-bottom shaped graft limbs.
Why?
The idea was the flare would expand and seal, but long-term durability has become a concern. The artery wall there is often diseased too.
So they might leak.
Exactly. There's evidence these flared limbs, especially wider ones over 19 millimeter, have a higher risk of type IB endoleak leakage at that lower seal point. Studies comparing them to modern iliac branch devices generally show better long-term results with the branch devices.
So bell bottoms might be out of fashion. What else do they do for a good distal seal?
Well, if the artery is really wide, say over 25 millimeters, or the aneurysm goes right down to involve the internal iliac origin, one option is to extend the graft further down into the external iliac artery.
Okay.
When you do that, you typically have to block off the internal iliac artery proximally using coils or a plug to stop blood flowing backwards into the aneurysm sac from the IAA.
Is that easy to do, blocking the IIA?
It can be technically tricky. The IAA is often twisty with lots of branches. It can add time, contrast dye use, radiation exposure, maybe cost.
Right. Any other approaches?
There's a hybrid approach, especially for large CIAAs. Place an aortouniiliac graft aorta down to just one external iliac, then coil off the IIA on that side, and do a surgical fem-fem bypass between the legs to keep the other leg perfused.
Sounds complex.
It adds a surgical graft, yeah, but fem-fem bypasses hold up reasonably well long-term, especially if open repair isn't a great option for the patient.
Okay, lots of options.
Yeah.
What about just covering the IIA opening with the stent graft without actively blocking it with coils? That done?
Yes, that's another strategy. Just letting the main graft overlap and cover the IIA orifice. Sometimes that provides an adequate seal.
Does it work?
Mixed results. One study found no difference in outcomes compared to coiling it off first, similar claudication, reintervention, survival. But another series reported low type 2 endoleaks but higher reintervention and claudication rates with just simple coverage. Conflicting data. Yeah. So while it might be okay for some, if you don't get a perfect seal, you risk long-term failure from that retrograde flow. Plus, covering it makes future access to that IIA much harder.
So the decision depends heavily on the anatomy at that junction.
Exactly. How it splits, whether the aneurysm actually involves the IIA origin.
We keep coming back to preserving IIA flow. What specific endo techniques are used to actively maintain that flow, especially in high-risk patients?
Right. If the other IAA is blocked, or there are bilateral CIAs or high risk of spinal cord issues, you really want to keep at least one IIA open. Guidelines recommend it.
Okay.
We know blocking one IIA is usually okay. If you need to block both, sometimes they do it stage block one, watch closely for pelvic problems, then block the other later if tolerated.
To actively preserve flow.
One way is that surgical external to internal iliac bypass we mentioned earlier, rerouting flow. Interestingly, studies suggest the collateral flow from the same side, external iliac and femoral, is actually more important for the IIA than flow from the opposite IIA, so maximizing same side inflow matters.
Okay.
There are also reports combining endostenting with unilateral IIA embolization and a contralateral external to internal bypass. Promising results, though some mild claudication was seen.
And robotics.
Yeah, there was that small series using total robotic laparoscopic repair with a special graft designed to preserve IIA flow. 100% success initially, but very early data. Still exciting.
Definitely. Okay, let's focus specifically on aneurysms in the internal iliac itself, IAAs. You said managing those is tricky because of all the branches. How do endo techniques tackle that while trying to keep the pelvis perfused?
It's a major challenge. The IIA feeds so much pelvic organs, buttocks, thighs. Blocking it off, even unintentionally, can cause problems. There's even a classification system for pelvic ischemia severity after IIA occlusion, class 0 to 3.
Right.
And studies have found predictors of problems like narrowing in the other IIA or poor collateral vessels from the femoral artery that increase the risk of claudication if you sacrifice an IIA. So careful pre-op assessment of pelvic circulation is vital before deciding to embolize an IIA.
So it's not just about plugging the aneurysm. What are some specific techniques used for IAAs?
Well, comparing iliac branch devices, IBDs, versus just covering the IIA opening, one study found coverage had better technical success and fewer reinterventions, but more buttock claudication.
Okay.
Another idea is selectively preserving just the superior gluteal artery, SGA, a major IIA branch. Maybe keeping that one open is enough to prevent most claudication.
How would you do that?
Carefully placing covered stents to exclude the aneurysm while keeping the SGA origin open, then coiling off other smaller branches. Needs precise placement and knowing the anatomy well.
Right. What other novel techniques?
Lots being tried. Direct stenting if landing zones allow. Chimney grafts parallel to the main limb. Sandwich techniques with stents side by side. Crossover chimneys for retrograde flow. Double barrels. The banana technique with retrograde II stenting, though durability concerns there.
Wow, a whole toolkit.
Yeah. For heavily calcified ones, maybe a hybrid. Embolize distal branches first, then open resection. Even just coiling the IIAA sac alone has been tried, with okay results, but some transient claudication. And the intrahypogastric sandwich for distal IIAAs, but limited long-term data.
So a really complex area with ongoing innovation, which brings us back nicely to iliac branch devices, IBDs. You said they're designed specifically for this IIA preservation problem. Tell us more.
Exactly. Devices like the Gore Excluder IBE and the Cook Zenith ZBIS are engineered to maintain flow into the IIA while treating common iliac or aortoiliac aneurysms.
Let's start with the Gore IBE. It's the one available in the U.S.
Correct. FDA approved since 2016. It has features like a low-profile delivery system, it's repositionable before final deployment, and you can access the IIA branch from within the device itself, which is convenient.
And the results.
Studies comparing it to open repair show potential benefits like fewer transfusions, shorter ICU, and hospital stays. Pivotal trials reported high technical success, good short to midterm IIA limb patency, and low rates of new buttock claudication. Real-world registry data seems similar so far.
So SVS guidelines recommend it.
Yes, for anatomically suitable patients. But like all newer tech, we still need more long-term data on durability.
Makes sense. What about the Cook ZBIS? It's been used longer outside the U.S.
Yeah, since 2006, so more long-term experience internationally. It has a preloaded curved catheter designed to help cannulate the IIA branch, often from the opposite groin.
Okay.
Deployment involves partially deploying the main body, introducing a sheath into the IIA branch, then deploying a bridging stent to connect the side branch to the native IIA. It also has modular sidearm options for flexibility.
And the outcomes internationally.
Pretty good. Studies report 5-year IIA patency, often over 90%, good side branch patency too. Reviews show a range of technical success, occlusion rates, claudication, endo leaks, reinterventions, generally showing it's a valuable tool.
So both devices seem promising. What does the really long-term experience, say 10 years out, tell us? Any limitations showing up?
Longer-term single-center studies looking at both devices generally show high initial success, but some early failures were seen, sometimes linked to aneurysms in the hypogastric artery itself or just the learning curve.
Right.
But overall, good long-term freedom from reintervention and good hypogastric patency. One study flagged hypogastric aneurysms as predicting reintervention and cautioned against very short distal landing zones.
Okay.
Another study on the Cook ZBIS noted procedural difficulty as a risk factor, and the big European pelvis registry, with over 700 repairs, showed good 6-year patency overall, but found aneurysmal hypergastrics and needing bilateral treatment increased the risk of late failure.
What about other devices like the Jotech Iliac?
That's another European one since 2014. Flexible design, movable side branch. Initial 1-year study results looked good, high success, good patency, low reintervention, but again, waiting on longer-term data.
It sounds like even with these specialized devices, they aren't suitable for everyone. Are there anatomical limitations?
Absolutely. That's a key point. Despite being designed for adaptability, both Gore and Cook IBDs can struggle with really complex anatomy. Strict adherence to the manufacturer's instructions for use the IFU would exclude a fair number of patients.
How many?
Some studies suggest maybe up to 52% might not meet strict criteria. Often, the IAA diameter is the issue, and real-world registries confirm that off-label use outside the strict IFU is pretty common.
So what happens in those off-label or unsuitable cases? Are surgeons adapting?
Yes, there's growing data on using these IBDs off-label for bilateral IAAs without aortic involvement, isolated CIAAs not meeting aortic extension criteria, sometimes with comparable results. There is even that small series using a balloon expandable stent as a proximal extension for a Cook IBD.
Interesting workarounds. Any difference in how the devices handle tricky anatomy?
One study compared how conformable they are. It suggested the Cook ZBIS might alter the iliac shape more than the Gore IBE, hinting the more conformable Gore might be better in very twisty arteries to avoid kinks. Another European trial linked short seals and poor Cook ZBIS conformability in elongated external iliacs to reinterventions.
So device choice might matter depending on the twists and turns. What about the really complex cases where even off-label IBDs won't work?
That's where the ultimate customization comes in. There's now been a first successful report of using completely custom-made fenestrated endografts for iliac aneurysms, grafts built with precise holes to line up with the IAAs.
Truly personalized medicine.
Exactly. It shows how the field keeps pushing boundaries for the most challenging anatomies.
It really does sound like a constantly evolving landscape.
It is. Early and midterm IBD results are promising for eligible patients.
Huh.
But these innovative hybrid techniques and custom devices keep addressing the unmet needs. And for all these options, we're still gathering that crucial long-term outcome data.
Okay, fantastic overview. Let's try to quickly summarize the key takeaways from this deep dive on isolated iliac artery aneurysms.
Sure. So, main points. IAAs are often silent, hidden deep, but potentially very dangerous if they rupture.
Right.
Diagnosis really depends heavily on imaging, like ultrasound and CT,
Okay.
and management has evolved dramatically, with endovascular techniques becoming central, including these sophisticated iliac branch devices designed to preserve that vital pelvic blood flow via the internal iliac artery.
It really makes you wonder about the future, doesn't it?
Yeah.
Will we see more and more of these custom-designed endovascular solutions becoming the norm, allowing truly personalized, minimally invasive repairs for even these really complex cases?
That's a great question to ponder. It certainly seems like the direction things are heading. And hopefully this deep dive has given you, the listener, a solid understanding of this complex topic. If it sparked your interest, definitely check out the sources or explore further. This was just scratching the surface, really.